What if one of the most life-changing screenings in dentistry doesn't have to cost you anything more than a little bit of attention? Today, we are talking about BROOMS. It is a fabulous way for dental clinicians to start connecting the dots, not as a scare tactic for you or for patients, but as a way to now shift the lens on things that you're currently seeing and amplifying that into dynamic conversations that can deepen your understanding and deepen their own as to the connections between oral dysfunction and oral health. Welcome, welcome, my friends. I am Carissa Laguerre. I'm your Myo best friend. If you are new here, I am here. I try to be very regularly, just to try to give you guys a little bit of an enhanced learning opportunity. There is nothing quite like this in the field right now, and that makes me sad. And so you got to be the change you want to see in the world. And so I'm here giving over 100 hours of education so far, with lots more to come, I am sure. But today we are focused on some more introductory topics because the more I hear that people don't know about myofunctional therapy, or they've never heard about it, or the only people they know that are talking about it aren't giving the real good goods on it, the more I know I got to step in and I got to do what I got to do to help you all really be able to thrive in this, because it's all about the ripple effect. The more I'm able to help you, the more you're able to help others, and then we all are increasing our reach and getting better and better and better. So give me a hi, a hello in the chat if you are watching here live. If you are not watching live and you're watching the replay, this is not the only content I have. If you're behind, you could be behind because you're not subscribed yet. So subscribe if you're watching on YouTube. You want to hit that like button and the follow, comment. We got to keep this thing going. Like, it doesn't happen in a vacuum. Yes, I get it. A lot of people are really scared about myofunctional therapy winding up being something that, everybody's doing and now nobody's going to make any money. But that's just not the way the world works, right? There's over 200,000 dental hygienists. There's over 200,000 dentists. And nobody is out of work. There's a lot of different doctors, a lot of different specialists, a lot of different speech language pathologists, occupational therapists, and nobody's out of work. It's okay for us to all be myofunctional therapists. There is abundance around us. You walk through an airport and you'll see there's not enough time for you to treat all the people who need your help. So keep this going. Let's expand the reach. Subscribe if you're watching this on LinkedIn. Give me a hi, hello in the comments, and connect with me, okay? That way you don't miss any updates and you're in the loop with how everything is progressing when there's another live stream. Okay, my friends. Now, we know that dentistry has a very, very big connection with systemic health, right? Yes, insurance companies have designated that the mouth and the eyes are separate from the rest of the body. And so, coverage only has to happen one way. But we know that the oral systemic link is around and that it exists. But beyond that, there's things that you're seeing every day, because people think about airway and they think about all the wrong things. You're thinking about sleep, you're thinking about upper respiratory like constriction, you're thinking about CBCTs, you're thinking about advanced level tactics that you're thinking are going way over your head. You're just going to stick to your usual traditional dentistry. You don't need anything else. If you got that, you're good. The problem is that you are seeing things every day that are connecting to generalized inflammation. You could be seeing somebody who has no idea that they have an autoimmune condition, and you could be the first person to actually see it if you know what to look for. And or you could be the person who finally connects some dots that traditional medicine is not able to sit down and talk about it. So if we're only looking at things from our lens and our perspective, then we wind up seeing a lot of problems. We wind up seeing people with hyperactive gag reflexes. We wind up seeing people who have bruxism, they have wear facets, they have audible breathing, they're fogging up your mirror. You're seeing all these things and you're writing them down as red flags in dentistry. And absolutely they are. You're doing the right thing. However, what we are missing is what's functionally driving it, and that we could be a part of the solution. Yes, oral dysfunction can be resolved within dentistry. It does not have to be something that's its own separate entity. It could be done within the dental practice. It's just people aren't talking about it like that. They're talking about it from this singular lens, singular focus. But myofunctional therapy, the ability to look at oral dysfunction, it goes so vastly beyond all the things that you anticipate. So I would challenge you to remain curious. That is science. If we're going to call ourselves evidence based practitioners, like dentistry is all about being evidence based, guess what science is? It's remaining curious. It's asking questions, building a hypothesis, testing that hypothesis, for failure. Okay? You're not testing it to prove yourself right. You're testing it to prove that it can't be wrong. You're trying everything to make it wrong, and it's still coming up all gold. And so remain curious. That is how real evidence base is built. We have to actually test things, right? If I want to test gravity, I have to be able to throw something up and it stays up, and there's no forces, be it seen or unseen, that are going to put it back down. I have to be able to understand how I can test that in a dynamic amount of ways. So if you're seeing somebody that's got a hyperactive gag, it can't be, oh, well, they were just born like that, or their mama had a hyperactive gag, so clearly they're going to have a hyperactive gag. That's not the way that works. It's all about how you're able to now connect things that you know are disruptive and start connecting them to what you're already doing, having the conversations, and remaining curious as to why all of this is occurring. If you start asking yourself more questions, why is hyperactive gag a thing? Why do some people have it and some not? Why is malocclusion a thing? Why do some people have it and some not? Why are there some people in families who need braces or who are severely crowded and others who are not? Why are there issues with certain people mouth breathing and others, they don't? They just nasal breathe just fine. They've never had an issue with any sort of mouth breathing. Remain curious, because the more you're able to ask yourself these questions, the better off we all are in the long run, your patients and yourself professionally, because now you're going to have enhanced knowledge. You can have better conversations. Okay. And that is where Brooms comes in. It starts these conversations. This is a repeatable way to organize the stuff that you're already seeing at a high rate. Now, a lot of people say to me, well, not a lot of people, but certain people say to me, there are lots of screeners out there for Airway. Like, why is Brooms special? One, it was made by hygienists for hygienists. Okay. I co created Brooms really out of looking at other screeners that were out at the time, and most of them I didn't think were fair at all. No matter what their name is, I didn't think that they were fair screeners. Anything that adds extra time as a clinical dental hygienist at that time when Brooms was developed, that was not happening. Okay. I'm the type of hygienist, and I don't know how many of you there are out there. Like, raise your hands in the comment, give me a high yes, I get it, I understand. But I'm the type of hygienist who, if we're running behind and I'm, running ahead or I'm running on time, I will be in the back. I'm doing instruments, I'm, doing sterilization, I'm coming and grabbing another person from somebody else's schedule. The doctor says somebody needs a cleaning. All right, awesome. Just toss them in. We'll make it work. I'll do what I have to do with an assistant, or many times without an assistant. Like, I will make it happen, because that's just how I go. I am go, 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 right? And we have to get these things done. And I don't want to disappoint anybody. Super people pleasing. That's my identity, right? And so if you're going to tell me, hey, I want you to start screening for things, and I want you to start looking at tongue ties and measuring things, like, I don't think any dental clinician has any real role in the whole tongue tie conversation. Like, if you cannot navigate an intelligent conversation with another human being about the trifecta that really does make up a tongue tie. So, it's the structure, which is just one part of a trifecta, it's the function, which is another, and then it's the symptoms, which is a third. If you cannot assemble that tertiary conversation and talk to how all of these parts are really impacting that person as an individual and whether or not that means that they need a release or they don't, they need some functional work, then you shouldn't be looking for it. And that would add significant amounts of time to a dental visit. And so I thought we need something that I would appreciate as a clinical hygienist. As a clinical hygienist, like, it's gotta be fast. I'm moving fast. It better move fast. Don't add not one thing to my schedule that's not going to be fast, fast, fast. I'm working at a faster pace than my mind can even go. And so brooms came about because it needed to be simple, right? And so I was thinking through all of this and talking to a colleague, and we finalized this version of it. And this is something that's been published and talked about. And the most recent one was the RDH Magazine one. And even that is still like 2 years ago. But before that, it was Spear Education. And it's been published in Dental Sleep Practice Magazine. This is a phenomenal screener. This screener is legit. Does that mean that it's been independently validated and tested? No. But let me tell you what, nobody has ever contested it within the industry. Nobody said, brooms is nonsense. It goes over things that have nothing to do with airway. No, because it absolutely has everything to do with airway. And it's quick. How long does it take you? As a dental clinician, I want you to think this to yourself because we're about to run through this fast, 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 okay? How long does it take you to determine that a patient is a bruxer? Yeah, seconds, less than a minute, yes or no. Many of them you might know if you've been somewhere long enough just by looking at the chart. Or there's people in your mind right now, you're like, yeah, Bob. Like, you know exactly who they are. Bruxers. Do they brux, yes or no? How long does it take you to determine if you can hear someone breathing in your chair? Audible breathing, yes or no? You don't have to even take any separate time for that. It's like, did I hear you breathe? If I can't remember, I probably didn't. Okay. Orally defensiveness. Now, this one I love because sometimes people ask me about it, but more often than not, hygienists, y'all know what orally defensive is. So it's that person who you're just trying to get in their mouth to work, like you just trying to do your thing, and they're pushing you out before you can even really fully get in. Like, the tongue is pushing you out, their cheeks are tightening up, their lips are uh like open. Uh okay, but like, I need to look behind there. Like, all I want to see is your mandibular anterior teeth. Why is this a battle? Should not be a battle. That's your orally defensive person. How long does it take you to determine if they are orally defensive? Like, yes or no? It's seconds, 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 fast, 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 babes. You know whether or not someone is doing some of this function. Open mouth posture might take you just a second more of thinking, but a lot of times, okay? Maxillary transverse width, a narrow vaulted palate. Like, how long does it take you to determine that? You're looking up there anyway. Like, yes or no? And then strain mentalis, which also might take you just a little bit of thinking. But by the time you've gotten down there, you've gone through 5 things, okay? 2 or more in the affirmative column. Yes, audible, yes, yes, narrow, yes. 2 or more is definitely somebody that we need to consider for referral or recommendation for myofunctional therapy. Okay. And that's the short on brooms. Okay. But I'll tell you, there's a much longer version of it. And if you just hang in there with me, we're going to go through all of these, all all 6 of these, and we will, and we will actually get to the nitty gritty of all the connections. Okay. So we're going to go one by one by one. You like this little icon here, this little broom icon? This is cute. So, bruxism. I think, and I hope everybody knows that this is not just a tooth problem. This is not just a stress problem, okay? And it might not be what you think it is. Hell, It might not be what I think it is, okay? But what it certainly is parafunction. It is not how the body is intended to act and perform. So a parafunctional habit is any habit that is not intended for the use that it is being performed at that time, like bruxism or mouth breathing, lip biting, all of this stuff, thumb sucking, these are parafunctional habits. So we know that bruxism is a parafunction. When we're looking at it, though, what we need to think is like, how can this potentially correlate with sleep fragmentation? How can this potentially correlate with occlusal overload? How can it correlate with compensatory behaviors? Because these are the things that are really the connectors and the drivers. You see, when you see somebody who is a bruxer and they're bruxing, be it conscious during the day, so they've got their teeth together, they're just grinding away. Or sometimes, if you're really attentive and you're watching a movie, you'll see the actors flex their masseters in a scene, especially some of them that are thinking. There's some very prominent ones that will think and just you just see those masseters flex out. You're like, oh man, I'm sure that you're a clencher. You're trying to remember that line. But the things that you're seeing, these wear facets, fractures, chipping on the occlusal surfaces, when you're seeing any sort of linea alba or the line along the cheeks where there's just traumatic lesions because biting, biting, biting. These bruxisms are telling you a story. They are telling you the long and the short of the quality of their ability to sustain an open and patent airway, their ability to really regulate, self regulate, their ability to maintain autonomy of their bodily function. Most people don't want to brux. Most people are coming up with a lot of problems as a result, direct result. So they've got more dentistry that's going on. They've got more dysfunction and orofacial pain that's occurring. They've got more tension and complaints along the shoulders, and especially so they've got the chin, the neck, the shoulders. They are complaining about all of this. They don't want to brux. Most people, when you have an audible bruxer, it's even worse. It's like to the nth degree, right? So it's like I could have just a small cavity that we might be watching, or I could be a fully blown out tooth. There's levels to this bruxism thing. And to the nth degree is the audible bruxer, where you're hearing it. Now, gone are the days where we keep talking about these things as if they are just something that is, oh, don't worry, it's just stress. We'll make you a night guard. The night guard does not stop the grinding. It doesn't stop the grinding. You're not hitting the source, right? So when you see a bruxer, you should immediately remain curious and think to yourself, well, I wonder what's really going on and underlying here. And it allows you to now start putting into place questions that may begin addressing the problem, that may begin saying, okay, we're going to paint this with a different lens. This is not just something where we're just trying to protect your teeth. I'm trying to protect your sanity. I'm trying to protect your airway. I'm trying to protect your sleep. I'm trying to protect your ability to self regulate your autonomic nervous system. That is what we are protecting in reality. And how do we protect that? Is it a night guard alone? No, because sometimes night guards actually make the problem worse. It doesn't make it better. It might stop any more dental, you know, fragmentation of the teeth or any more dental chipping or whatever happening. Great, but it's not preventing the functions and the muscular activity that's occurring. Alternatively, Botox does not stop it from occurring either. It's like a temporary paralysis. If you were hitting yourself in the face all day long and, I paralyzed your arm so that you couldn't hit yourself, we never resolved what muscular function is causing you to hit yourself. As soon as the Botox starts wearing off on your arm, you will continue to hit yourself. Can we just continue this pattern of just like we just hit ourselves and we just accept that that's what it is? Let's freeze the arm or cut it off, because why not? Just cut it off. Then you could stop hitting yourself. That seems like the most obvious answer, right? Mm-mm. So we're remaining curious because and this is super important. If we only start to look at what's broken, if we're only charting, documenting, addressing what's broken, we're missing entirely the whole intent of the pattern that's breaking it down. And once you know the pattern, you can start connecting it to better solutions. You can start connecting your patients to better solutions. I was having a conversation, and this is probably going to come up in the next live. And this is me on a rant, y'all. So just follow me, okay? Because I promise you, we're going to get into respiration in just a second because I need to breathe. But we are in this day and age where people are apparently forgetting all that's happening around them. And so they're thinking to themselves, oh, I need such and such a certification, or I need to be affiliated with such and such organization because that's going to protect me. Mm-mm. Mm-mm. We're missing a big pattern that is currently broken within our industry that we aren't understanding enough as it is to then say like, oh, in the near future when like more than 1% of dentistry tends to care about airway or myofunctional therapy, yes, me being a part of this random organization will totally protect me. That's not the way that works. That's not how things are actually processed. So when we have things that are introduced, new legislation like the OPAs, right? And everybody talks about the OPAs now because that's like the big thing in dentistry, and they're trying to get our our assistants to have more responsibilities that will help to cover some of what people are calling, this vacancy within dental hygiene where nobody's able to find one or hire a hygienist or keep one, I guess. But instead of solving that problem, we're just going to, skip right on over. Now, the fact that we graduate CODA, the fact that we are licensed, like none of that protects our abilities to do hygiene in any way, shape, or form. We can have our responsibilities, our scope of practice given out to just anyone who takes a couple of courses and does some hours of certification. Yes, you too can do hygiene because it clearly isn't that difficult. I don't know what I went to school for, but it clearly wasn't that difficult. But if the OPAs and the world in which this disassembly of our very structured, very routine, down to a science licensure can be broken down and distributed amongst others, like what is to make you think that if this was put into dental scope of practice, myofunctional therapy, whatever, it put into dental scope of practice, that you would be protected because you have some certification? Like your license isn't protecting you from your scope of responsibilities being distributed to other people. So I just don't understand it. I'll never understand the whole certification thing, but we're going to talk more about that on another live stream because more and more people have been asking me about it, and more people I've been telling. It just don't make no sense. So we're going to chat about it. However, let's get back on topic because respiration. Oh, I love that. I think this picture is everything for me. Respiration, when you are hearing people breathe, breathing is inherently supposed to be something that is inaudible. You can't hear it. You shouldn't in no way, shape, or form hear somebody breathing. Now, there's a lot of wives out there and maybe some husbands, but there's a lot of wives out there that'll tell you, oh my gosh, I can't stand the way he breathes. He is breathing all the time. I can hear my husband breathe. Sometimes you really can't hear him breathe. Like you listening just a little too hard. You looking for any little like obstruction in the nose to cause an audible breathing sound. That's not what I'm talking about here. I'm talking about you really are hearing them as they are breathing. You are hearing every inhale and exhale. Like it is coming hard and fast and they have no control over it. This is something that you should be able to rapidly assess. Now, does that mean that immediately biofunctional therapy? No, they should probably go see an ENT. They need to talk to their physician about this. Like, there's a lot of different people along the way, most definitely a pulmonologist, but they should be talking to other people about this as well. And if they haven't had those conversations, it's a great one to have. More people are going to see their dental hygienist than they are going to see some of these other things. There are whole families that will go to a dental appointment and the father figure or the dad or the mom hasn't gone to go see their primary physician. They have not had a physical in years. They've been taking care of the children, making sure that everybody else is well and good. And so they might not have asked those questions. They might never see those people, but they might see a dental clinician. Yes, they would come into you and they will sit, and this is their like hour. This is their hour where it's peace. Like, oh, I just get to sit in this chair. I don't have to do anything. Like somebody just comes up and like cleans my teeth for me. This is great. That's how I process it in my mind. This is great. Now, when there are red flags like audible breathing, or those people who come in and who are like, oh, they're congested again. Now, there are people who tell me, and I'm always asking, I ask everybody about congestion now all the time. There are people who tell me that they are congested year round. I have seasonal allergies. What seasons? Um, all of the seasons. Guess what? You don't have seasonal allergies. You're just chronically congested. Okay, if there are some seasons where you can't really differentiate the pollen or whatever, you like it doesn't matter. There could be 10 feet of snow on the ground and you still are sneezing and heaving at the life. That's a problem. Okay, there's a problem. Audible breathing, chronic congestion, dry lips, dry mouth, you know that a lot of this is going to affect saliva production, saliva pH. Oh my gosh, that's such a big thing that we don't talk about enough. Maybe we need to have a whole conversation too about pH and pH testing and all that that could mean and tell us and the bacterial profiles, but we're not going to go there right now. You know that that audible breathing is definitely impacting the moisture of the tissue within the mouth. Okay, what are the bacterial profiles in the mouth, their sleep quality, because sleep is, yes, regulated by breathing and breathing patterns. You can't get into restorative sleep if your body is fighting for your life. It's trying to keep you alive. So respiration is always priority number one in the sleep cycles. And so if we've got to wake you up so that you can still continue to live, then we're going to wake you up so you continue to live, and then your body's in panic and it's trying so hard to just keep you awake. These are conversations that people are not having. But guess who they can have them with? Their dental clinicians, the people who could say, this is something that I think we need to put in our chart. We're going to watch it for now. I want you to be more vigilant about this. And then we'll see who we might need to talk to next, because we might need to refer you to our favorite pulmonologist. We might need to send you to our favorite respiratory therapist. We might need to send you back to your primary care physician because you need that. Okay. Don't confuse respiration with open mouth. Open mouth posture is quite literally they're walking around with model mouth. They're walking around with their lips just apart for no reason. No reason. I tell my kids sometimes, like, are you just out here catching flies? Like, that's your whole job in life, is just to see how many will fly into your mouth. Now, granted, I don't say that very often these days, but that used to be a thing. It's like, oh, you're just out here catching flies. And they knew immediately to close their mouths. But I think that it is something that we need to note as dental clinicians, because it's more about what are they doing in these long periods of muscle function. So the times that you are not speaking, eating, drinking, like when you're not doing any of that function, what are your muscles doing? Are they at rest? Are they hyperlax? Are they hyper engaged and not clench? What is happening during that? This is long term muscle function, and that muscle function needs to be accounted for. What people don't think about is that we know inherently and understand that we can change the physical shape of craniofacial structures, right? There's been new evidence that's come out now that people who dig their nose tend to pick their nose, I don't know, dig their nose, pick their nose, whatever, tend to have larger nostrils because you're literally making the nostril bigger. Your finger is in there crafting that space. You suck your thumb. Your thumb is in there crafting that palatal space. So we know that muscles and force and function really do impact the shape. Why would you think that it's okay for us to just have lax lips? The teeth and the jaws are going to respond to these muscles not being in the place that they should be. A lot of times they say that the lips are kind of like a fence. It keeps the teeth from all of that proclination that we don't want. But I'm telling you that it could be that way, or it could be a force too far inward that can make them retroclined. Like our bonus on this slide, lip hooking. People always ask me about that. Lip sucking. Lots of people who do that. Lip biting. You're creating now an additional parafunctional force inward. So we want to look at it both ways. It shouldn't even be just open mouth posture, but if you're looking for something, the easiest thing to find is the open mouth posture. But I would even mark this section yes if I see lip parafunction in any capacity, if I see dry lips, if I see that the tongue is resting in between those lips. Like if that's the rest posture, whew, we got so many problems. Okay. So this is definitely something that we want to start talking to people about because there's no way that you're in proper tongue posture, which is our tongue lightly suctioned up to the palate from the front all the way to the back, okay? People like to say, like, the incisive papilla, and you want to have your tongue start there, and everybody knows spot, but nobody knows that it should go all the way back to the soft palate. And if you can't feel your soft palate with the back of your tongue, then you need to work on some of your awareness of your posterior tongue. And then from there, the strength, the function, and the ability to sustain. So you want to build that up over time. But our open mouth posture, I think, is incredibly important for us to start noting down and to start giving patients that little interim of conversation that this is a big influencing driver in how the teeth are positioned, in how your gums react, in how airway function occurs over time. It's important. Start having those conversations. My favorite O, oral defensiveness. It's a fun one. If you're noticing that they're orally defensive, a lot of people are already inherently a little bit concerned about that. Some of our very high sensory people, the people who are most anxious in the chair, the people who are like, oh, I just can't stand it. I don't want to be here. That's great, Susan. We didn't want you to be here either. Like it's just that same flow of conversation that they're giving you when you feel like you're ready to just give it back because you're so tired of like the fight and people coming into the office but like wanting to fight you even though they voluntarily came and sat into your chair. You did not ask anybody to get up. You did not kidnap anybody and bring them to your office. They came on their own free will. They're still anxious about it because their body is in a protective mode. Their airway is being protected, rightfully so, by all of their muscles, and they're adapting to what is probably a really small environment, what is probably an environment that hasn't been adequately stimulated, that does not have proper posture, and so therefore they're lacking some proprioception intraorally, and too far forward mapped is that hyperactive gag. And so we want to make sure that we are staying on top of the orally defensive people. They need us the most. So the orally defensive ones, those gaggers, those people who have the tongue. So uh, you ask them to open their mouth, you don't see nothing but tongue, and you're like, why is your tongue up so high? Hi, sir. Relax your tongue. Just relax your tongue. Can you open a little wider? And it's nothing but tongue that you're seeing. That's all you're seeing is tongue. You're like, what's going on? What's going on? Why aren't they listening to me? They're protecting their airway. Their soft palate is probably very low. Their uvula, you can't quite visualize it. You can't see it. And still, we're actually able to stimulate a gag because it's just mapped too far forward. In the first 12 months of life, it should be mapped in the posterior third of the tongue, but it doesn't get mapped there for whatever reason. And so there's a lot of work that needs to be done there with like sensory stimulation and all sorts of things that we love to do as myofunctional therapists, but we can really engage the velopharyngeal space, we can engage posterior tongue, we can do a lot of proprioceptive work and help to facilitate a calming of this. And you'll notice that they'll be able to relax their lips more. They won't be so defensive and pulling in and preventing you from just scaling 24 and 25. That's all you've ever wanted to do is just scale 24 and 25. That is like a hygienist's dream. We love to see the calculus come off, and that's where it builds up the most, those lower anteriors. And you are robbing us of every opportunity to be able to enjoy that moment by having that lip feel like it's about to break my fulcrum finger. Okay? We can't do that. And so we got to start having these conversations like, there's more to this. I understand that you are defensive and you have no control over it. You need to gain some control over your oral musculature. And what I want you to do is to start taking note when you're going to brush. Are you finding it difficult to get there? Are you finding that your tongue is pushing you out of the way? Is it difficult for you? If it's difficult for you, imagine over time how that's going to make this oral cavity and maintaining the health of it work. How is that going to work? It's not going to work for us. We're going to have to find a way for us to make this a more appropriate relationship for us. Okay. And so, what I want you to do is just be more aware. And like getting the patients to be more aware is step one. Step one is to know that you have a problem because then you can solve the problem. RM. We're almost through, guys. RM, maxillary transverse width. How long does it take you to know if somebody has a vaulted palate or, a narrow arch? Like, it really doesn't take you long at all. And the real key here with this maxillary transverse width section is that it's our work area that is giving us all the clues to the airway. How do I know this? Because every time you've looked at a palate, you've actually looked at the maxillary bone is also the floor of the nose. You've looked at the floor of a nose. If it is narrow and vaulted in the mouth from your oral view, what do you think it looks like behind here? It doesn't look great. It does not look great. What do you think their breathing volume is? The nasopharynx, like what? Where do you think is where's the air going? Anywhere? And then they sit down in your chair and they're chronically congested, and you're like, I don't know. You do know. You're looking. You're looking right at the nose. Every time you ask somebody to open wide, those defensive posture people and the people who you just, even if they're not defensive, they may not have a hyperactive gag, but you can in no way, shape, or form see into their throat. Like you have no visibility. You don't know what their tonsils look like. You don't know what their uvula looks like. It just looks like droopy soft palate and tongue. That's all you're getting out of there. That should give you a lot of red flags or at least yellow flags to caution on the topic of their oropharynx. Like what's going on behind all of that? If the soft palate and the back of the tongue are in the airway, what does that upper respiratory tract really look like? I think you have some of the best clues because who else is looking back there? Exactly. Every time you've seen a mandible, you've seen the anterior and lateral borders of a airway. So if it's retruded, if you feel like, oh man, that jaw is recessed, What do you think the airway looks like? The airway clearly does not look good. It's impinged upon. Its anterior and lateral borders are blocked. And so it's really important that you start realizing that our work area is all airway. It's all airway. Okay? So every narrow palate, every vaulted palate, every time you've seen somebody with all sorts of crowding, anytime you're like, ooh, this child is going to need braces, like these are the people that you're like, raise my hand in curiosity. What's going on? There is more here to the story. The shape of those jaws are going to give you the most clues about their growth, about what their rest posture is, any parafunction, what the nose and nasal volume looks like, and if they'll be able to achieve any real orthodontic stability, because can you sustain the shape even when it's altered, when you have poor adaptive functional muscles that are surrounding that space? No, it's just going to push everything back. I could do a palate expander, and then if I go back and I suck my thumb, I can mess up everything that I've gained, right? So what do you think happens when the tongue's not where it's supposed to be? It's a big thing. This is very important that we start reinforcing these things in our mind. The strain mentalis is also pretty big. Strain mentalis. The mentalis muscle is your chin muscle here, okay? So it kind of looks a little like that, like these two fingers. It looks there. So these muscles, when they are really, all muscles can relax and contract. That's it. That's what muscles do. They relax and they contract, okay? When they are contracted, it looks like the dimpling on an orange. It looks like an orange peel, right? And it looks just really hyper engaged. That is too much investment in this area here. Why, when all we've got, what is the mandible? The mandible here? Why does the mandible need this much pressure and strain on it? Why should the muscles be working this hard on the mandible? If we wouldn't want that kind of muscle function for bruxism, right? We wouldn't want that same engagement of the masseters. Why would you want it on the mentalis? We should start paying attention to the mentalis, right? It's a very big indicator of compensatory patterns. A lot of times they might go to swallow and you'll see bunch right up. There's a lot of concern there that you need to be on top of. And so when you see the chin muscle working too hard, you just have to know compensations occurring, chin dimpling, lip strain on closure. If they close their lips, so they come in and you know they're mouth breathers, but they're acting like they're not, they might be just as pursed as the woman in this image, might be looking just as tired and strained. That muscle has been working too hard. The muscle is on overtime and it would like to take a vacation. Okay. We got to start thinking about it as something that, red flag, red flag. Because, and I felt like this was so important that I need to put in here twice. If we are only looking at what is broken, what is wrong, and we are documenting that, we're going to miss entirely all of the systems that are breaking it down. And we can't afford to do that. So here's where we're coming to a head, in that we need to have this as a standard that we're all looking for. But nowadays, nobody's doing anything that's free. I can't tell you how many free things I signed up for that I don't do. So I think it's really important that we all start doing the things, and we start getting into these things and start investing our time and effort into these things. So the Myo launch is on myolaunch.com. If you scroll down, it's the new course. the Myo Launch. And it is a wonderful course. There you go. That's just 2 hours long, 2 hours long, made for hygienists to really understand. You get to deep dive there on brooms. There are 4 modules. We're going to talk about all 4 of them very briefly. Module 1 is opportunities. Where are the opportunities to start introducing myo or airway in dentistry? Why is now the best time to start screening? What are the tools that you can do so? And how is it going to impact you professionally? What conversations should you start having with scripts and all with patients, with your employers? If you don't own your own practice and you're a dentist, yes, dentists can take this course too. Or if you want to start getting your team involved, because we need the team to make it happen, to make anything happen in a dental office. So module 3 and 4, I'm sorry, I skipped over 3. There you go. Module 3 and 4 are going into documentation and monetization. So documentation, all of the things that you should start documenting and how to document it. If you're like, oh my gosh, Broom seems so great, I got to be able to start documenting this. Well, don't worry. You'll meet me in the Myo community and we'll get that done. You'll be able to do that. But what I really want to stress is that this is a $10 investment with so much value. I just had several hygienists finish the course. They've got wonderful reviews, and I think that it's really a game changer for absolutely everybody. So if you're thinking like, oh man, I really need to start my screening, I need to start screening better, and I need to start figuring out how I can get this in my practice, how I can do myofunctional therapy, what are the options for me? The Myo Launch is absolutely the way to go. Okay. Now, additionally, those of you who are interested in just starting with brooms, because you're like, ooh, I understand it, Carice. There's definitely some things that I need to start looking for in my chair. Awesome. I want you to do that. And I need you to do that on the Myo community and Facebook. Just ask me for it. I'll send you the file, and then you'll be able to have the brooms document. That way you can, start really putting this in. Because I don't want you to add time. I don't want you to add time. I understand. I've been a clinical hygienist. I am one of those overachievers. I am a people pleaser. And if you're going to ask me to implement anything, it better be quick. Otherwise, you're going to PMO. Okay. Hopefully, y'all all know what that means. But this is not about adding time. This is not about added effort. This is about taking what you're already looking at and looking at it with a new set of eyes and looking at it better. Starting to document things so that you can now have a higher sense of understanding as to where your patients are, and so that you can become more curious, so that you can slowly take the steps. You don't have to jump in 2 feet right away. You can slowly take the steps to start implementing Airway or Myo, or start having the conversations. It's all about remaining curious. Okay. So, with that, my friends, I'm going to check really quick. I don't think I saw any comments with any questions, but yeah, no comments, no questions. Okay. With that being said, my friends, I am so honored to have been here with you for yet another live. I hope you all have the most fabulous day, weekend, evening, wherever you are. I love you all, and I'll see Mayo. Your Mayo best friend is out. I'll see you next time. Bye.